Our guest today is Dr. John Campbell. He is a board-certified vascular and endovascular specialist with over 20 years of experience in our local hospitals. Welcome, Dr. Campbell.
Thank you, Dr. Rashid. It's a pleasure being here today with you.
Our topic is vascular and endovascular surgery. Doctor, you've been involved in the hospitals in this area for over 20 years. And in the past year, there's been some major changes in the medical care in the Valley. And tell us a little bit about your position now versus what it was a year ago.
Well, I was at CAMC for most of my career and made a change 6 months ago to join WVU Medicine at Thomas Hospital. My partners, Dr. Megan Jordan, Dr. Stephen Haas, we all came together. First day was January 29th, and we're really excited about the new opportunity.
Well, I think it's great. Both hospitals, but particularly Thomas now, have promulgated the cardiovascular and the heart attendance for our patients much more. It's been quite a change for the doctors, the hospital, and the patients.
Yeah.
But now you are starting a vascular surgery department, or I guess what you're doing now, the endovascular and the vascular, is sort of new to the Thomas system?
Yes, it's been growing over the last 2 years, and we continue to evolve. We pride ourselves on being state-of-the-art. I personally do endovascular surgery, which is performing intervention with balloon and stents and newer technologies that are minimally invasive. And then my partners do that, but also do open surgery when bypass is needed. And they need to clean the arteries out manually with surgery. But definitely we are growing that program at Thomas and very excited about it.
So you don't actually do open surgery, as we call it. You do, how would you describe what you do?
So it depends on how you want to describe it.
Yes.
So the newer term is usually endovascular surgery. In the past, it's also called an interventionalist, but you take catheters and you take wires and you cross blockages. We have tools that clean out those vessels when you need it. We do balloon procedures, stent procedures. We have catheters that can literally remove clots by breaking the clot up, and then you literally aspirate the clot out of the body, where before you would have to make a cut in the leg and then pull those clots out.
We showed you guys how to do that with cataract surgery.
There you go.
Yeah, a long time ago. So you go in and chop it up and suck it out.
Yeah. And so every year, the care of vascular patients with innovation and technology, it's a huge growing field, and it's just really an exciting time to be doing these procedures and taking care of patients.
So you don't make an opening, you go through the blood vessel system, like doing a heart stent?
Exactly.
Do you do brain stents?
We do not. So
some people do, don't they?
Yeah, it's neurointerventionists perform that.
Okay,
yes.
That's a specialty.
What I tell everybody is I fix basically every artery or vein in the body except for the heart and the brain. And then we take care of everything else.
All right, so you're there at Thomas now. You have certain specialties. So Thomas is increasing their outreach to patients, particularly in super specialties as your own.
Yes.
So they are expanding their facilities. And in fact, one of those new facilities is the new cath lab.
Yes.
Yes. So tell us about the hybrid cath lab.
Very excited about the hybrid cath lab. It's going to be state of the art. It will allow us The reason it's called a hybrid cath lab
Yes.
is traditionally you would either go to the operating room and get an open surgery,
Yeah.
or you would go to the cath lab and get a endovascular procedure or intervention. The hybrid cath lab allows you to mix both those procedures, where if you need a partial open procedure, say you have severe blockage in the lower extremity, and you need the artery cleaned out in one section, but you can fix another part of the artery with a stent or a balloon, you can do it all in one place. So that's the traditional part of having a hybrid cath lab. Now, what makes it very exciting is the imaging capabilities. These are designed that your imaging capabilities allows you to do very complex, especially aortic procedures, where you get mapping, and it just really opens the doors for what you can do for patients.
So when you talk about complex endovascular procedure and imaging, you're talking about x-rays or what? You're not making an opening.
So what you use is, it's called fluoroscopy is what we use. And
Yes.
fluoroscopy, we inject contrast or dye into the vessel, and then we watch that contrast go through the vessel, and that shows us when there's blockage in the arteries, and then we can then treat the vessels.
So if you have a problem with vascular supply to different organs in, let's say it's to the spleen or something, you can do that externally?
Yes, we go in a lot of times through the femoral artery.
Yes.
And then can go into the splenic artery. And a common procedure that we sometimes have to do is to block off the splenic artery. If you're in a traumatic situation where you have bleeding, we can go in and block that bleeding by going into the splenic artery or treat an aneurysm in the splenic artery.
Interesting what happened to me when I had COVID. It hit my mesenteric artery and knocked it out. So I had some problems when I was in the hospital.
Yeah.
So that wouldn't be correctable unless it was just from a clot. You could go in and remove the clot?
Yes.
Do you put anything in place, a stent or anything in the vessel like that?
It depends on the situation. If it's clot secondary to plaque, hardening of the arteries,
Yes.
as people would call it, then a lot of times you may have clot there that has to be removed, and then you need to stent the vessel, or in some cases do an open bypass. If you have clot that forms, say, from your heart,
Yep.
a clot forms in your heart and then goes to the vessel, then a lot of times it's just removing the clot, if there's a normal vessel left behind.
So if I had a cardiac valve problem, you could do that externally. You don't have to open it up. Is that correct?
Well, with the cardiac valve problems, that is where we see some of the structural heart with cardiology and with CT surgery. They do a lot of that now via transfemoral access, where they can do percutaneous valves. Our team does not do that, but in HVI, the Heart and Vascular Institute, we do have team members who do perform that procedure.
So we should call the femoral arteries the highway to healthy heart.
Yes.
Or healthy health.
Yes. Yes.
It's amazing what we do through that. Okay.
Yeah.
So now you work for the West Virginia Heart and Vascular Institute.
Yes.
That's number one. And you practice at Thomas Hospital. Now explain the difference between the two, because most of our people have not heard about the West Virginia U Heart and Vascular situation. What is that all about?
So I work for the West Virginia University Heart and Vascular Institute. We say HVI,
Yeah.
and that is through WVU Medicine. And the institute is affiliated with over 100 hospitals and clinics. There's over 1,500 team members, and our whole goal is to provide care, quality care for patients in West Virginia and surrounding areas. And with Thomas, the goal is to provide care in southern West Virginia.
So you cover the whole state almost, 100 different clinics and all.
Yeah.
That's amazing. Now at Thomas, because you're into this type of thing now, we actually have a heliport.
Yes.
Do you ever go up in a helicopter?
I have not. No. That's not something I have done.
So the whole concept of West Virginia Medicine Thomas is to bring very sophisticated care to the local population.
Yes.
Is that a good overall statement?
That's a very good statement. That is, our goal is to provide quality care, state-of-the-art care to this region with vascular diseases.
Well, what did our patients here do what would they do if you're not here? What would they have to go to Morgantown or Ohio State or what?
Yeah, they would have to go to surrounding hospitals and yes, go to other facilities. We hope to provide. Our whole goal is to provide truly patient-centered quality care for those and give them that opportunity.
Well, now that you're here and we know you're here, how do we call upon you? And what does the vascular specialist team do specifically?
So our goal is that we get referred the patients, and patients can also do self-referral. We take care of venous problems. Common problem is patients have swelling in their lower extremities. We see patients for that. And then we take care of arterial problems. Peripheral arterial disease is one of our most common disease processes we take care of, which is where you get blockage in the lower extremities. We take care of carotid artery blockages, which to prevent stroke, kidney artery blockages, or what we call renal artery disease.
You can save a kidney that way?
Yes. Yeah.
That's fantastic.
If they have blockage in the kidney artery.
Yeah.
Yes.
What else?
Take care of the mesenteric vessels, take care of aneurysmal disease. So if you go back years ago, if you had an aneurysm in your abdomen or an aneurysm in your thoracic aorta,
yes,
that was always treated with open surgery. Now most of those patients receive what's called a stent graft, which is percutaneous, where we put that graft in and treat the aneurysms.
Well, I have to say this. As a child, my father constantly told me about my distant cousin, and he performed some of these things and devised some of these things, and that was one of the reasons why I think I became a surgeon. You remember the surgeon I'm talking about, I believe, Michael DeBakey?
Yes.
And he actually created that surgery for the aortic arch aneurysm, which nobody would touch. And incidentally, at age 96, he had that surgery. And I had met him when he was 94. He survived another 3.5 years after having that.
Oh, wow.
Now, as I understand it, that surgery, you only have about 45 minutes to do all of that, or you lose a patient.
Very complex procedure.
Yeah.
Yes.
Do we do that here? Does one of the specialists do that, or will they be able to do that?
Our goal is to be able to do that. Dr. Vinay Badwar, he's
Yes.
the executive chair of the cardiovascular thoracic surgery department, and Dr. Dans performed the first open heart procedure in March of this year. Very exciting.
We're going to show a picture
Thomas.
of him with the patient. Yes.
Yeah, and so the cardiovascular surgery program is growing, and our goal is to be able to do those procedures at Thomas. We are not performing those procedures yet, but that is the goal in the future. And having the hybrid cath lab we talked about opens those doors, and that department's going to continue to grow.
So with the hybrid lab, they may do preliminary procedures and then still have to send them and have open procedures. Is that correct?
That's
correct.
correct.
It's a stepwise.
And sometimes we work with our thoracic surgery, cardiovascular surgeon colleagues to do procedures where we work together to treat aneurysmal disease in the aortic arch with aortic dissections, aortic aneurysms, and that's where we're opening these doors to performing these procedures.
That's
very
amazing.
exciting. Yeah.
I was
exciting.
excited when I found out about he did the first open heart surgery at Thomas.
Mm-hmm.
Historical note, I performed the first eye surgery at Thomas Hospital on July the 5th, 1968.
Wow.
That was the first one ever done there.
That's amazing. That's awesome.
Thomas and I go back a long way.
Yeah.
And it's exciting watching them because at the time they had no facilities, and so we had to get them for them. They couldn't afford them. But they've become a major eye center now. Are these complex procedures done on a daily basis?
We see patients or involve patient care on a daily basis. I guess it's what your definition of complex procedures.
Yes.
But we perform a lot of complex procedures. Is it every day? Not every day, but we are always available to do the complex procedures when they arise.
Yeah, I know you had one last night, if I remember.
Yes.
Okay, so as a patient, do I call you up, say I want to speak to Dr. Campbell, I'm having some kind of a problem? Where do your referrals come from?
Most of our referrals come from primary care physicians in the region, in the community. We have patients who do self-referral, call, and one of the things I love about WVU Medicine is that they are patient advocates. So we want to increase access to patient care. So patients can call, and if they think they have a problem with a vascular problem, their leg swelling, they can self-referral. And I love that about WVU Medicine. But most of our patients come from primary care physicians and other specialists when they have a vascular problem.
Now, does our general physician population know that this is now available and how they go about getting patients to you?
I hope so. We are trying to get the word out that we've changed locations, and I think we've done a good job of that. But I do think that information is getting out there. Our goal again is to make sure that that people have access to us and know how to get a hold of us. So we are working on that daily to get the word out.
Well, that's important because many patients, particularly those who have disabilities and old age, so to speak, or they're getting older, it's difficult for them to go to Ohio State or Cleveland Clinic or something like this if we didn't have these procedures here. So in many cases, they don't follow through and don't have anything done.
Yeah, I have, through the years of doing this for a while, I've had so many patients say to me when we talk about, say, going to Cleveland Clinic or to Mayo, they say, I can't go out of state. I can't do that. And so that's why every healthcare provider in the state needs we really need to work on providing state-of-the-art care where our patients don't have to travel outside the state to receive medical care. It is hard on a lot of our patients to travel. And
cost-wise, travel-wise, family, to get them there is a big deal. So you have two major problems. You have to educate the physician population, what you can do, and then you have to educate and take care of the patient after they're referred to you.
Yes.
And one of the hardest ones is going to be to educate the medical profession what you do.
You're right.
That's why you're here.
That's why I'm here. That's why I'm here. Yes. Yes. No doubt.
Okay.
Yes.
So that do you have any specific programs now to teach the doctors what is available out there?
The main thing what we do is we do outreach. So we've gone to physician offices just to do meet and greets, and I do think one of the best ways you can get the word out is just go in person. So that's mainly what we've been doing, is going to physician offices and educating about what we do and what we offer and how to get a hold of us and how to refer.
Okay. So what are your team, what are the clinical areas of their expertise or your clinical expertise? Because there's differences I'm learning from you. Tell us about that.
So I'm a vascular medicine specialist. My background is internal medicine, and then I did a vascular medicine fellowship, and I do endovascular surgery. So all of our
Explain that.
endovascular, yes.
That means you don't have to open up, you go through the highway of vessels.
You go through catheters, wires, and you don't open patients up, and,
Okay.
and you do minimally invasive surgery, endovascular surgery. So that's my specialty. I also try to focus on medical therapy for vascular disease. If you look at a patient, say, with peripheral arterial disease, which is blockage in the leg arteries, and you look at their 5-year outcomes, they have a very high risk of cardiovascular events such as heart attack and stroke and cardiovascular death. So another aspect of the care we provide is to make sure they're on the right medications to prevent those events. And that's called secondary prevention. So that is also a passion of mine to not just treat the vessel, but treat the patient. To encourage walking, to encourage smoking cessation. Unfortunately, in our state, diabetes
Yes.
and smoking
Yes.
are
High
rampant.
blood pressure,
High blood pressure.
obesity. So you have the road cut out for you. You got a long road to go.
Yes.
So you actually, if I refer a patient to you and you determine they have some of these chronic problems, they might not necessarily go to surgery immediately. You may follow them, or how do you handle this? I've been sent to you. What do you do to me?
So when a patient is referred, we see him and evaluate.
Yeah.
And we look at it from multiple ways. One is the medical therapy. Another is to determine if they need a procedure. Most of the patients I see don't need procedures, but they need followed. So they need medical therapy, and then we have to do what's called surveillance. Say you have carotid artery blockage, and you have a 50% narrowing of the vessel in the carotid artery.
Yeah.
That does not need treated unless you're having symptoms from that artery causing a stroke-like symptom. But it needs followed to make sure it doesn't worsen to the point that it does need treated. And so we do every 6 months to 1 year, we do an ultrasound to make sure it's not worse. We see them in the clinic. And then we're also making sure they don't develop blockages in other areas.
So that blockage, when you're talking about that, that's not a blood clot. That's actually cholesterol plaques or something?
Correct.
Aha.
Yes.
So, as I understand it, sometimes do you go in and clean that out with the vibrations of the system you use?
So with carotid artery blockage and
Yes.
narrowing, there's several ways to fix it, and we select those ways based on the risk of the patient for surgery and also the anatomy of what's safest for the patient. So a carotid endarterectomy can be performed. I don't perform that procedure, but my partners do, where you make a cut in the neck and literally remove the plaque from the artery. Most of those patients go home the next day. It's a very well-established surgery and the gold standard. Then you can get a carotid stent, and there's 2 ways to do that. One is from the groin, going through like a catheterized femoral artery again. That is not done as often. And then there's a newer procedure called a TCAR, where literally you make a small cut in the neck and put a stent in through the neck artery, and that's done in the hybrid lab. That's one of the classic procedures done in this new hybrid lab that will be developed here shortly in November.
Well, that appears or sounds like it might be easier than going through the femoral.
It is, and that's why the femoral is not done as much anymore, because the data for that procedure is very good. And so that has really taken off. And again, we talk about innovation, that it has really advanced as one of the mainstays of doing treatment for the carotid artery blockage, as well as still doing the carotid endarterectomy as well.
Now, you're part of this forum of the 100 clinics and all that are into endovascular surgery. Now, are these procedures that you're telling us about available in all of those? Or do you get many of your referrals from those outlying clinics that you have these agreements with?
We get many of our referrals from those outlying clinics. There are several hospitals within the state that do offer vascular procedures, but when you look at the majority, we have the centers that do those procedures, and we get referrals from several of those smaller clinics. Yes.
It sounds like you've been pretty busy since you started.
Very, yes. We're growing daily, and that's good.
Yes.
We are very happy about that.
Well, Thomas is doing many things and expanding many things. That's where the cath lab comes into. But what else are they doing that's new that helps all patients, but also the ones you take care of?
I tell you, I've been there a little over 6 months.
Yes.
It's daily changes. You can't go around a corner without seeing construction, new things being built.
Seeing or hearing the hammer.
Oh, it's really, the clinics are beautiful. They're building. With our pediatric program that is being developed. It's hard to even pick out one thing. We doubled our critical care capacity in just the last year. Under the leadership of Dr. Rosencrantz, he's the president and CEO of the Thomas Hospital System. I have been astounded. I've never seen anything like it at how fast the growth is happening. In the last 6 months, we've added over 50 physicians and providers to the system.
Well, I have to say quickly, I remember when Dr. Rosencrantz was here years ago. He has been on the show since. But when I was in the hospital with one of my COVID events, he actually made rounds on me. I thought it was because it was me. Then I watched, and he made rounds on other patients in the hospital.
He prides himself on
and
being...
his staff was with him.
Yeah, he prides himself on being a physician first, and I think an administrator, wouldn't say second, but he's still a very good physician. Let's put it that way.
Real quick, what is Thomas doing to advance medical care in our state, or medical education at Thomas?
So that's very exciting. We have had, at Lewisburg, the osteopathic school has had students come to Thomas for a while now, but we just got the ability to have WVU fourth year students come to Thomas.
What about the needs at Thomas itself as far as training your staff? What's available to the people out there, very quickly?
They're always doing education programs at Thomas for their staff. It's multiple programs for education at Thomas. Yeah, they do a great job with that.
So
yeah.
We need nurses. We need technicians.
We have a need for critical care, ICU nurses, medical assistants. The job opportunities are immense at Thomas.
Thank you, Dr. Campbell. Appreciate that. This is Dr. Richard C. Rashid praying that you will see a bright day.